Heparin Induced Thrombocytopenia. British Society of Haematology, BSH. Recommendations. Introduction. Heparin is a bioproduct produced from pig intestines. Exposure to heparin may lead to heparin binding to platelet factor 4. Heparin PF4 may then act as an immunogen prompting primarily IgG antibodies. Heparin PF4 IgG complexes then bind to platelets plus monocytes causing platelet activation, aggregation, and consumption. Further PF4 release. Tissue factor expression on monocytes. Activation of endothelial cells. This combines to create a highly procoagulant state with thrombocytopenia and a high risk of thrombosis. Autoimmune HIT. Autoimmune HIT is a severe subtype of HIT that features both heparin-dependent and heparin-independent platelet-activating antibodies. Autoimmune HIT disorders include delayed-onset HIT thrombocytopenia that begins or worsens despite heparin cessation, persistent HIT that persists beyond a week after stopping heparin, heparin flush HIT, and most cases of fondaparinux-associated HIT. Autoimmune HIT is caused by similar IgG antibodies that are reactive against PF4 heparin complexes but which activate platelets even in the absence of pharmacological heparin. Spontaneous HIT. Spontaneous HIT, non-heparin triggers such as knee replacement surgery and infection, predominantly heparin-independent platelet-activating antibodies. Presentation of HIT. If HIT is suspected in a patient receiving heparin on the basis of a fall in the platelet count, the probability of HIT should initially be judged on clinical grounds. 4 features are particularly helpful in estimating the likelihood of HIT. Timing. Platelet count falls 5 to 10 days after starting heparin. Severity of thrombocytopenia. Platelet count falls greater than 30 to 50% from baseline. Nadir count usually less than 55, but less than 15 is unusual. Thrombosis. 25 to 50% develop associated thrombosis. Common, DVT, PE, arterial thrombosis. Other, skin lesions, venous gangrene, adrenal bleed, total global amnesia. Alternative explanations. Consider the many other, more common causes of thrombocytopenia. These factors form the basis of the 4TS scoring system. Assessment of HIT. Patients who are to receive any heparin should have a baseline platelet count. We suggest platelet count monitoring be performed at least every other day from days 4 to 14 or until heparin is stopped, whichever is longer, in patients on UFH infusion. We suggest platelet count monitoring be performed at least every other day from days 4 to 14 or until heparin is stopped in post-cardiopulmonary bypass patients receiving LMWH. We suggest platelet count monitoring be performed at least every other day from days 4 to 14 or until heparin is stopped for medical or surgical patients receiving UFH by subcutaneous injection at therapeutic or prophylactic doses. We suggest that routine monitoring of platelet counts in postoperative patients other than cardiopulmonary bypass patients receiving LMWH is not required. We suggest checking a platelet count 24H after starting heparin in postoperative patients and cardiopulmonary bypass patients who have been exposed to heparin in the previous 100 days and are receiving any type of heparin. We suggest not routinely monitoring the platelet count in medical patients and obstetric patients receiving LMWH. HIT should be suspected if the platelet count falls by 30% or more and/or the patient develops new thrombosis, skin allergy, or any of the other rarer manifestations of HIT are noted between days 4 and 14 of heparin administration, and a clinical assessment should be made. We suggest calculating the pretest probability score in a patient with suspected HIT. If the pretest probability score is less than or equal to 3, no further laboratory investigation is recommended for the majority of patients, except rarely for patients treated in the intensive care unit. Laboratory testing to exclude HIT despite a low pretest probability score is suggested in a selected small number of patients treated in intensive care units, especially those supported with extracorporeal membrane oxygenation. If the pretest probability of HIT is greater than or equal to 4, heparin should be stopped, and an alternative anticoagulant started at therapeutic intensity while laboratory tests are performed. Screening recommendations. Lateral flow assays should be performed only on fresh samples to avoid technical problems. PAFAs should not be used in isolation for first-line HIT screening. Enzyme-linked immunosorbent assays and chemiluminescence immunoassay. ELISAs used for the initial investigation of possible HIT should have high sensitivity greater than 95% and detect only IgG antibodies. A positive result in an ELISA for anti-PF4 antibodies should be interpreted in conjunction with a clinical estimate of pretest probability to make the diagnosis of HIT. HIT can be excluded by a negative high-sensitivity ELISA antigen assay. Reporting the results of an ELISA for anti-PF4 antibodies should include the cutoff for a positive test and the optical density obtained on the test sample. When confirmation of HIT is required, activation assays should be used to demonstrate inhibition of platelet activation with excess heparin. It is recommended that donor platelets be confirmed to be sensitive to HIT-positive material prior to use. Selection of laboratory assays for diagnostic algorithm. All HIT testing should be performed in conjunction with pretest probability scoring. HIT reporting should include assay-specific thresholds. The stratification of numerical assay results should be used to increase sensitivity, specificity, and negative predictive value. Functional assays performed by expert centers should be considered for confirmation of HIT where possible. Spontaneous HIT. Warkentin and colleagues proposed the following criteria for making the diagnosis of spontaneous HIT. Thrombocytopenia with no alternative explanation. Thrombosis. No recent heparin exposure. Presence of strongly positive PF4 heparin antibodies detected in ELISA, with greater than or equal to 2 different assays. A strong positive platelet activation assay greater than 80% peak serotonin release featuring strong heparin-independent platelet activation greater than 50% serotonin release at 0 IU ml heparin, as well as additional heparin-dependent platelet activation seen when using diluted patient serum. Presence of other characteristic features of HIT SERA inhibition at 100 IU ml heparin and with Fc receptor-blocking monoclonal antibody. Spontaneous HIT recommendations. Spontaneous HIT should be suspected in a patient with thrombosis and unexplained thrombocytopenia but no history of exposure to heparin, especially following surgery or infection. Patients with suspected spontaneous HIT should be investigated with a platelet activation assay and demonstration of inhibition at 100 IU ml heparin and with Fc receptor-blocking monoclonal antibody. Patients with a VITT-like syndrome, e.g. patients with MGCS or following recent adenovirus infection developing thrombocytopenia and thrombosis should be tested for anti-PF4 platelet-activating antibodies using ELISA. In patients with suspected spontaneous HIT, treatment should not be delayed until all investigations are completed. Management of HIT including spontaneous HIT. Patients should be therapeutically anticoagulated for 3 months after classical HIT with a thrombotic complication. Patients should be therapeutically anticoagulated for 4 weeks following HIT without a thrombotic complication. We suggest recording the diagnosis clearly in the patient's medical record and proving the HIT alert card to the patient. We suggest evaluating and making an individualized plan for the duration of anticoagulation in patients with spontaneous HIT, as there is insufficient evidence to make a recommendation at present. Alternative anticoagulant, parenteral options. Alternative parenteral anticoagulants to heparin, such as argatroban, bivaludin, danaparoid and fondaparinux, should be used in the acute management of patients with HIT. Argatroban, danaparoid and fondaparinux are suggested alternatives to treat spontaneous HIT. Alternative anticoagulant oral options. A vitamin K antagonist with appropriate bridging with a parenteral non-heparin anticoagulant is recommended as an oral anticoagulant in HIT once the platelet count has normalized or returned to baseline. Direct-acting oral anticoagulants are suggested for use as oral anticoagulants in patients with clinically stable HIT. Role of intravenous immunoglobulin, IVIG, and plasma exchange in heparin-induced thrombocytopenia. IVIG 1 g kg for 2 days is suggested for patients with heparin-independent platelet-activating antibodies such as autoimmune HIT, spontaneous HIT and VITT-like disorders or severe HIT, and if a patient has a contraindication to the use of a non-heparin anticoagulant. Treatment with IVIG and/or PX is suggested in patients who have severe HIT syndrome or are presenting with a clear case of AHIT, when there is a lack of access to a non-heparin anticoagulant, or in cases where clinically significant bleeding prevents the use of therapeutic anticoagulation. Re-exposure to heparin following the history of HIT, including management of patients with HIT undergoing cardiac surgery, percutaneous coronary intervention and hemofiltration. In patients with a history of HIT, re-exposure to heparin should be avoided unless it is essential. Screening for platelet-activating PF4 heparin antibodies is recommended if re-challenge with heparin is essential in patients with a history of HIT. If the platelet-activating PF4 heparin antibodies are positive and surgery cannot be delayed, heparin should be avoided, and an alternative anticoagulant should be used. 2b. A functional assay for PF4 heparin antibodies prior to cardiac surgery is suggested for patients with a history of HIT. Patients with a history of HIT who are antibody negative, usually after greater than 100 days, requiring cardiac surgery, coronary intervention, including angiography and percutaneous coronary intervention, should receive intraoperative UFH in preference to other anticoagulants, which are less validated for this purpose. Preoperative and postoperative anticoagulation should be with an anticoagulant other than UFH or LMWH. Patients with active or recent HIT less than 100 days requiring surgery should be reviewed to assess whether surgery can be postponed until the patient is antibody negative, after which surgery can proceed as above. Use of bivaludin is recommended in patients with active or recent HIT with positive PF4 heparin antibodies requiring cardiac surgery, coronary intervention, including angiography and percutaneous coronary intervention if the procedure cannot be delayed. Use of plasma exchange plus or minus IVIG is suggested for patients with HIT needing heparin re-exposure prior to CPB or vascular surgery if bivaludin is not available and heparin use is essential during the surgery, with a change to a non-heparin anticoagulant following the surgery. In patients with a history of HIT requiring hemofiltration, a non-heparin anticoagulant such as argatroban, danaparoid, or citrate is suggested, as repeated exposure to heparin increases the risk of recurrent HIT. Patients with active HIT requiring hemofiltration should receive a non-heparin anticoagulant such as argatroban or danaparoid rather than citrate anticoagulation. Heparin Induced Thrombocytopenia in pregnancy. Argatroban, danaparoid and fondaparinux are suggested alternatives to treat HIT in pregnancy. A written management plan for intrapartum and immediate postpartum care is suggested, taking the pharmacokinetic properties of danaparoid, fondaparinux, or argatroban into account.